talk about margin, like
Yeah.
typically like these are in joint space, right?
Right.
Either like a knee or a hip.
Correct.
And how do you, because these are also growing and growing
That's
very
right.
fast.
That's right. That's
How
right.
do you choose these margins
Right.
intraoperatively? Because you know it's also growing at that time.
That's right. You know, the surgery is actually done on the day prior to actual incision. You know,
Right.
when I sit with all the MRI scans and the CT scans and the X-rays of the patient, I spend half an hour, good half an hour, you know, looking at those images, where I make a surgical plan. You know, and where I know that this is where my margins are going to be, this is where my knife is going to go, and this is where I go. This is going to be safe. And with the advent of good quality MRI, good quality CT scans, PET scans, we exactly know where the disease is ending.
Right.
And that is where we can actually calibrate, okay, this is where the disease is ending, I'm going to go 3 centimeters beyond that and cut it here.
Yeah.
But even then, intraoperatively, we send certain, you know, piece of tissue to the pathologist whenever we have some doubt, okay, and he will tell us, okay, this margin is free or this margin is involved by tumor, and then we can revise those margins. So a lot of things can be done, but with current level of imaging that we have, most of the times we are able to do a safe margin surgery on most of the patients. And intraoperatively, usually we don't have any surprises most of the times. Um, and you know, as I told you, most of these patients of osteosarcoma and Ewing sarcoma are children. And as you rightly said, you know, those tumors also happen around the joint. Say for example, knee joint is the commonest joint which is involved by these cancers. And when I remove that part of bone, the patient also loses the physis.
Yeah.
And the physis is the part of the bone which is responsible for growth of the bone.
Right.
So when the patient loses the physis, there is a risk of shortening. So the opposite limb will keep on growing, and this limb will, of course, not grow because that physis is lost. But as I said, if the physis has to be removed, it has to be removed, because oncology would always, supersede anything else.
Yeah.
But fortunately, there are multiple reconstruction options today, which would allow the patient to have equal limb lengths. You know, when we discuss further, maybe we'll tell our viewers what are those options.
Yeah. So maybe just building on to the question, the topic you mentioned about the physis.
Yeah.
Are these cases be only on one bone? Say for example, is it only on the femur and not on the tibia, or only on the tibia and not on the femur? And then in those situations, can you save the physis if there were ways to kind of predict, or it's mostly the cases that you oncology always takes over the function?
No. So basically, as I said, based on MRI imaging, we know the exact extent of the disease.
Right.
So many patients, the disease is only in the center of the bone.
Right.
You know, those patients we don't need to take out the physis.
Okay.
But if the tumor is, you know, very close to the physis, or almost touching the physis, that physis has to be removed. You know, so basically the disease extent would dictate the magnitude of resection, whether the patient will lose the joint or not, lose the physis or not, lose the, you know, shaft of the bone or not. Sometimes you have to remove the whole bone, you know, right from top to bottom, and reconstruct that defect as well. So basically, the disease extent would dictate what what magnitude of resection we have to do.
Understood. Okay.
Yeah.
Cool. So you know, maybe if you can share some of your examples of the cases that you have done, and you know what kind of implants you use, that would give us
certainly. And I mean, we can you know. But I think before we do that, I think we should tell our viewers as to what are the commonest reconstruction options that we use.
Yeah.
I mean, they would be curious if patient loses this much of bone, say for example, from knee joint up to half of this thigh bone, which is known as femur. Supposing this bone is lost, then how the patient is going to walk, isn't it? So there is a defect, say for example, 15 centimeter long femur is missing, along with with one side of the joint.
Right.
So we have to reconstruct this defect, and for that we have this kind of prostheses, which are known as mega prostheses. You know, so typically, you know, it will kind of fit like this.
Okay.
So this is known as stem, which
Mhm.
goes into the remaining bone,
Mhm.
and this goes into the bone
The tibia.
in the tibia or in the other bone, and this part was the resected type of a resected part of the
Hmm.
tumor or the
Okay.
bone. Now these are all modular prostheses. Now these days, when you go for shopping,
Hmm.
you get multiple sizes. You fit in 34 size, I fit in 40 size,
Hmm.
but you have every size available.
Right.
Similarly, we have now modularity even in the prosthesis. So if
Mhm.
someone, suppose on table I have to resect 16 centimeters, I can do that. I have to resect 20, I can do that. I have to resect 25,
Mhm.
I can do that, because everything is available to me
Understood.
intraoperatively.
Yeah.
So that much liberty we have today. When I started learning orthopedic oncology back in 2004, we used to customize the prosthesis.
Right.
We would have to measure it and send it to the company, and they
Manufacturer.
will make only one prosthesis.
Yeah.
So intraoperatively, we had no leeway, we had no liberty to even go here and there by one
Yeah.
millimeters. And sometimes it happens that we take a cut and we realize, oh no, this doesn't look good,
Mhm.
and I have to cut 3 centimeters more, but then we are stuck because
Yeah.
we don't have that liberty. Now today, because of the modularity, we have that liberty
Mhm.
of doing and choosing
Mhm.
intraoperatively what we can do.
Mhm.
Now, in fact, this is, if you can see, this is a fixed hinge prosthesis.
Mhm.
This is like a door hinge
Right.
which moves in one direction.
Mhm.
But when the joints that God has given us, they are not like that. When
Yeah.
you bend this knee
All
joint,
directions.
so they have some rotation between
Rotation.
these two bones also,
Mhm.
and that is why these hinges fail very fast. These
Mm.
typically 5 to 7 years, 10 years is the maximum life that you can expect.
Mm.
But like these then we have these kind of processes
Mm.
which are rotating
Rotating.
platform processes. So these processes were available for simple knee replacements previously.
Mhm.
Now even for tumor prostheses, these kind of joints are available, and these have very long survivalship for these joints.
Nice.
So basically, uh, all this technological advances are also helping our patients.
Yeah.
uh, Similarly, in children,
Mhm.
we have to have a mechanism by which we can keep the limb lengths equal.
Mm.
As I just said, if a 10-year-old
Yeah.
a 10-year-old child loses the physis,
Spices.
and if you put in this specific implant,
Yeah.
by the time he grows up, he'll be like 3 inches, three and a
Yeah.
half, 4 inches shorter
Shorter.
on this side.
Right.
So we have this kind of prosthesis, which is known as expandable prosthesis.
Interesting.
This is a small screw here, you can
Mhm.
see, and this is a key,
Mhm.
and there is a gear worm mechanism inside. So when
Mm.
you turn this,
Mm.
if you can see here, you can
Nice.
see here,
So yeah, it's like
it
growing.
is growing.
So just like physis, this is like
Right.
a mechanical physis
Correct.
in a
So
way
what you
to.
do is every
Yeah.
6 months or 1 year, you take the patient in the
Yeah.
operation theater
Right.
and look at this screw and turn it like 10.
Right.
Every 10 turns, it will expand by 1 millimeter.
1 millimeter.
So
Okay.
every 6 8 months, you
Right.
expand it by a couple of centimeters,
Nice.
and you might have to take the patient in the theater multiple times,
Mm.
but at
Mm.
least at the end of it, you have
Yeah.
equal limb
Equal
lengths.
limb length, normal walk,
Yeah,
and
correct.
function.
This is known as invasive expandable prosthesis,
Right.
meaning by you just have to you have to do this invasive procedure
Small
every time.
incision
Yeah,
and
small
make a.
incision. Yeah,
Yeah.
but now we have technology by which we can expand the prosthesis without putting an incision, which is known as non-invasive expandable prosthesis,
Interesting.
which is driven by an electromagnetic motor. So that implant has an electromagnetic motor
Mm-hmm.
fitted
Mm-hmm.
within the prosthesis,
Wow.
and uh, you know to make it simpler, you have to just connect it to a machine.
Mm-hmm.
Whenever you want to expand, you just
Yeah.
connect that thing on the OPD basis or at home,
Mm-hmm.
and you just turn a button
Program
and
it
it will keep on
and
expanding.
expand.
Yeah, so it's really fascinating. These are very expensive
Yeah.
devices, and they are not indigenously customized. They have to be customized from Germany.
Mm.
But patients who are affording,
Mm-hmm.
you can have that kind of a non-invasive expandable processes, which will avoid these multiple surgeries.
Yeah. Yeah.
So technology has really made a huge difference in especially in children, as far as the growth preserving strategies are concerned, in many patients. So yeah, I mean, because of these, our life has become much more interesting, and the patient's life have become much more you can
Normal,
normal.
like
Yeah,
to
you can you
how
they
they would.
can they can feel
Yeah.
that they are not different from their
Yeah.
colleagues, their
Yeah.
peers.
Yeah.
So yeah, I mean,
Amazing.
this technological advances have really helped us big time.
So much happening.
Yeah.
I see there are also hip cases like these.
Oh yeah,
And if you
this
can share
is
maybe
yeah,
something on
these are
these.
the, you can say, this is the future of surgery as far as the. So these are all the patient specific implants. There are situations where which were largely considered unreconstructable.
Okay.
Say for example, you have to say for example, a tumor was in the socket of the hip joint,
Right.
which is known as acetabulum,
Mm.
or a pelvic bone, and we have to take out that part of uh, the
Tumor.
bone. Say for example, you remove this part, so the patient will be left with only this much bone, right? Right. If you say compare this,
Yeah.
you take it out this much, so you will be left with only this much. Now it's
Right.
such a small bone.
Right.
So you have this is a 3D printed patient specific implant. This is actually a model. If you can see, the original implant almost looks something like this, and you can see this lattice structure, and you can see all these pores, and so you put it here, which
Right.
exactly fits so beautifully
Okay.
with this thing. So this is a patient specific implant. This implant will fit only in this particular patient.
Understood.
This implant will not fit in you or me. This will fit only in this patient.
Yeah.
And for this for this surgery to be precise,
Right.
the company also makes a lot of jigs,
Right.
which help us take a very precise cut.
Margins where
Yeah,
they to
yeah.
cut and
So
everything.
of course that plan has to come from the surgeon.
Sure.
Based on the MRI and all
Yeah.
these things. But then when you see this structure, ultimately when you like this will ultimately heal. These two surfaces will actually heal with each other.
Understood.
And that will almost make it a permanent,
Right.
kind of a reconstruct.
So it's like a bone with a metal
Yeah. So
attached to it.
So this is a non-biological implant,
Right.
but it is still biological reconstruction.
Right.
Because ultimately this is stimulating biology.
Right.
Yeah.
Okay.
All right.
Amazing.
Whenever you have to anchor an implant to such a small bone, the key to success is osteointegration. Meaning by you have to have a prosthesis which will eventually heal with the bone. Just like to cut end of the bone, when a patient has a fracture, you just put those fracture ends in front of each other, and then you put a plate or nail, and then naturally it heals with each other.
Yeah.
So if you have a technology wherein this implant can heal with the bone, that probably will last for a very long time. If you fit this any implant in such a small bone with the help of cement, it is going to give way maybe in 2 years or 3 years, not more than that. But if you see this prosthesis, you can see this structure. This is known as lattice structure.
Okay.
This is a titanium implant. It's such a small, such a lightweight implant. If you can see, yeah. And this is a lattice structure. And when you put an implant inside the bone with a lattice structure, it is going to heal with that particular bone. All these small crevices, the bone is going to grow in these crevices, and it is going to become a part of your bone.
Amazing.
Yeah. So in fact, we dread if you have to, for some complication, if you remove this, we dread that situation because it never comes out. It is so nicely healed with the bone, it just doesn't come out.
So it becomes part of the bone in a way. It becomes
part of the bone.
It's like
you see this defect.
Extension of the bone.
You see this defect, and you see this. It's so beautiful. It fits.
Right.
That is the beauty of 3D printing. If you have now softwares which can help you do this, and fortunately we have got very good companies who are making this good quality products.
So it's interesting that you have personalization in a way.
Yes.
Sometimes it helps, like in the hip situations, but there are also personalization in knee situations where you feel like, hey, intraoperatively, if I have to have flexibility, personalization is great, but not really, because I want flexibility in the surgery.
That's right.
If there's things that I find out in the OT, then
Absolutely.
I need to have the flexibility.
Yeah, so you have to have modularity in one area, and you have to have a patient specific implant in another area, and you can have mix and match of both.
Right.
So that is where I always tell people that the world is run by engineers. My operation room is full of engineering marvels and gadgets. Without help of a simple thing like a cautery or an AHU or a light, we can't do the surgery. And similarly, nowadays we are so much. I'm very happy that we have these kind of things, which is reassuring. For many years, maybe probably for 15 years of my practice, I was really worried or worry of using these kind of devices because I never thought we have a technology which will allow an osteointegration. But the moment someone came up with this kind of an implant which was looking good, and my first case when I did, it was so reassuring. We had, the moment I put the implant inside, I was so much happy and confident that this patient can walk with full weight bearing on the very next day, and that patient did walk.
Nice.
So we need this kind of reassuring technology, and and it should also transform in a very reassuring you can say workmanship. That is what is more important.
Yeah. This is I feel like this is the future that's already here, right?
Yeah,
But
yeah.
maybe if you can share, like maybe 5-10 years from now, where is this going? Like where do you see the future of orthopedic oncology heading?
So I think the future probably, I think we are talking about patient specific implants. I think in future, may not be in my lifetime, but uh, there is going to be a patient specific treatment plan,
Right.
meaning by this patient will respond to this particular medicine.
Right.
There are so many genetic markers that we now know, and there are probably thousands of them we still don't know. Tremendous research is going on where there is a patient specific treatment plan, meaning by, not today we are treating all the osteosarcomas in a similar fashion. I treat 100 patients in a similar fashion, 70 do well, 30 don't do well. And I don't know the answer why they don't do well. I think in future we'll have that clarity that okay, this patient will respond to this drug but will not respond to this drug based on a lot of sequencing and a lot of laboratory testing on the tissue samples. So there will be a patient specific treatment plan, including drugs, medicines, chemotherapy, immunotherapy, targeted therapy. And as far as the surgery is concerned, I think there is remarkable clarity already on the extent of resection and margin. And we have, now the focus is on those, on the longevity of implant. Basically all these are artificial things, and they are implanted in very young individuals like 13 years, 14 years, 10 years. Our only concern is how long it will last. And I think if we have a technology which can help last this artificial devices longer, that is going to be the game changer. Because and even today, even biological reconstruction, meaning by we have a lot of options wherein we don't put metal, but we put bones. There is a lot of progress happening on the levels of bone banking. Meaning by we can actually regenerate a bone in the bank and put it inside. So a lot is happening. The exciting times are going to come, and I hope earlier than later. But I'm pretty sure, because today, as they say, only one thing is constant, that is change. So it is going to, and already when I started learning my oncology in 2004, and in 2026, a lot has already changed. A lot has already changed. The understanding has changed, the technology has changed, the workmanship has improved a lot. I think even the patients profiles have also improved, patients understanding has improved. uh, Probably a bit of, because the economy is progressive, even their affordability has been improving. So all these things put together, I think we will probably see a remarkable improvement in the outcome of bone cancer patients. Even today, I think as a ballpark, 60 to 65% of the patients, they have long-term survivorship. Meaning by they get cured. Out of 100 patients that we treat, around 65 get cured. I think the primary goal is to take that number to as high as possible. And for that, alongside surgery, I think the medical oncology, chemotherapy and immunotherapy has to also evolve.
And
Yes, that's
the
right.
treatment
That's right.
personalization
That's
kind of
right.
is
That's
what
right.
is the
Correct.
next future.
Yeah.
Well, this is really fascinating, and it's really an honor to have you in our podcast. And thank you so much for all these insights.
Okay, then it was an honor to be here. I mean, I'm so happy that someone has actually taken pains to do a podcast on bone cancers, and that is really amazing. I really congratulate you on that.
Thank you. Thank you.
Yes.
It's a pleasure.
All right.
Thank you.
Thank you very much.